So you want to own a private hospital. Buy some land, put up a building, hang a sign that says emergency, and watch the money roll in from people who have no choice but to show up. That is what it looks like from the outside. Here is what nobody mentions before the first shovel hits the ground. A hospital bed, unlike a hotel room, cannot just sit there quietly losing you money. It sits there losing you money while a nurse, a monitor, an HVAC system built for negative pressure isolation, and a compliance department all keep running whether that bed is occupied or not. And here is the part that actually separates the winners from the ones who quietly sell out after 5 years. 2 hospitals can open 20 miles apart. Same bed count, same city, same population to draw from, and one becomes a regional powerhouse while the other bleeds out slowly until a bigger system buys it for parts. Same buildings, same patients walking through the door, completely different systems behind the scenes. Let's find out why. Private hospitals did not become dominant by accident. For most of American history, hospitals were charity institutions run by churches and cities. That changed after World War II, when insurance-based employer healthcare expanded and Medicare arrived in 1965, suddenly guaranteeing a steady stream of paying patients for anyone willing to build capacity. Investor-owned chains like HCA, founded in Nashville in 1968, figured out something the nonprofits hadn't. If you standardize operations across dozens of buildings, negotiate as one entity, and run hospitals like a business instead of a mission, you generate returns that attract real capital. That single insight built an industry. Now let's talk about what it costs to actually open the doors, because most people wildly underestimate this. Construction guides put the average at roughly $1 million per bed, and that number climbs fast depending on how much intensive care and specialty capacity you're building in. A modest 60-bed facility with an emergency department and basic surgical suites runs somewhere around $50 million. A full-scale hospital, 300 beds, everything included, lands well past $200 million. And that number is climbing. Plumbing materials alone jumped 8 to 9% in the back half of 2025. Labor. For the mechanical and electrical systems, the most complex part of any hospital build, is running ahead of general inflation because there simply aren't enough skilled tradespeople to go around. You are not building a building. You are building a small, self-contained city with its own power redundancy, its own medical gas lines, its own water systems, and every single one of those systems has to pass inspection before a single patient walks in. Here is where it gets brutal. The building is done. The doors are open. Now, every day that a bed sits empty, that potential revenue is gone permanently, exactly like an unsold hotel room, except your costs are far worse. You need registered nurses on shift, around the clock at a ratio far higher than any hotel needs housekeepers. You need a functioning emergency department, whether 1 patient or 50 walk through it tonight. You need malpractice coverage, and depending on your specialty, mix that alone can run from a few $100s per low-risk provider into the tens of thousands for surgical specialties, because the average malpractice payout in the U.S. now exceeds $350,000, and severe cases settle for $1 to $5 million. National data on hospital occupancy puts the average around 66%. But that number hides something important. Small hospitals under 25 beds tend to hover near break-even. Mid-size hospitals, the 26 to 250 bed range, have posted negative operating margins for years running. It's the exact opposite of what you'd expect. Bigger isn't automatically safer. It's messier. Let's run the math on a 100-bed private hospital. At 60% occupancy with a reasonable payer mix, you might collect somewhere around $400 million a year in gross charges before adjustments, but that number means almost nothing, because what actually lands in your account depends entirely on what insurers and government programs agree to reimburse, not what you bill. After adjustments, staffing, supplies, drug costs, debt service on that construction loan, you could easily be sitting at a 1 or 2% margin. Push occupancy up 10 points and improve your payer mix even slightly, and that same building can swing from barely surviving to genuinely profitable. Nothing about the physical hospital changed. The only thing that moved was utilization and the deal you cut with insurance companies. That is the entire game. This is exactly why standalone hospitals keep getting swallowed by bigger systems. And it's worth understanding how. When you're one hospital negotiating with an insurance company, you have almost no leverage. When you're part of a 200-hospital system like HCA, which pulled in $75.6 billion in revenue in 2025, across roughly 190 hospitals, averaging close to $400 million in revenue per facility, you negotiate reimbursement rates from a position of real power. You buy supplies at system-wide volume. You share back-office functions, billing, compliance, IT, across dozens of properties instead of paying for each one individually. HCA posted a 13% operating margin in 2025. Independent hospitals, on average, are lucky to clear one or two. That gap is not talent, it's scale. Private equity understood this math years ago, and the pattern that follows an acquisition is remarkably consistent. Emergency department salary spending typically drops around 18%. Total staff headcount falls by roughly 5%. Bed count often shrinks slightly as underperforming units close. Cost per patient discharge drops by several $100s. Some of these acquisitions squeeze out real efficiency. Others just squeeze. The healthcare M&A market itself has cooled from its post-pandemic frenzy, with disclosed hospital deal multiples compressing to around 12 to 13 times. EBITDA in early 2026, down from nearly 15 just 2 years earlier. Higher borrowing costs did that. Buyers got pickier, and this is where the industry starts to feel less like hospitality and more like private equity playing a very long, very quiet game. Now, the part that determines whether you survive year 10 or get absorbed by year 5. Debt is the killer. A hospital financed heavily against future occupancy projections can look fine during a strong flu season and then get gutted the moment volumes soften, because the mortgage on that $200 million building does not care what your admissions numbers look like this month. Deferred maintenance is the slow version of the same disease. Skip your capital reserve fund for a few years to protect short-term cash flow. And when a major piece of equipment fails, an MRI suite, a sterile processing system, there's no reserve to cover it. So you either take on more debt or let quality slip. Quality slipping shows up in outcome data almost immediately, and outcome data drives referral patterns from doctors far more than any advertising ever could. Picture the two outcomes side by side. In the good scenario, your hospital affiliates with a larger system gains negotiating leverage on payer contracts, keeps occupancy above 70%, and maintains its capital reserve religiously. You're consistently profitable, if modestly. In the rough scenario, the same building carries too much debt, skips a maintenance cycle, takes a quality hit after a bad outcome makes the local news. Referrals dry up, occupancy drops, and within 18 months, you're not running a hospital anymore. You're running a liability looking for a buyer, because that's the final truth of this business. A hospital is not really selling beds. It is managing a system where real estate, payer negotiations, clinical outcomes, staffing, and reputation all have to move together every single day without pause, because unlike almost any other business on earth, you cannot afford to be closed for even one night. The building is the vehicle. The system running underneath it is the entire business. And the difference between the hospital that gets bought for scraps and the one that anchors an entire regional health system was never really about the beds at all.